Hi, Smart News. Hope you're having a great day. We're going to take a little moment today to talk about that headline about the Johnson & Johnson COVID-19 vaccine and what it means, and take all your questions and try to sort through it. I know it's an alarming headline, and one maybe that we didn't expect, that we woke up to this week. So I'm excited to take a moment to sort of digest this news. And one of the great things about Smarter News is we don't have to rush to a commercial break. We're not confined to 2 to 3 minute segments. We can actually sit here and work through it together, and that's a great thing. I got one baby napping. I have 2 kids in front of PBS. I have a husband on a conference call. So let's all hope for the best. So let's just start with 3 quick things I think you need to know about this. We don't have a whole lot more information besides what we learned yesterday, which is that we had 6 reports out of 6.8 million doses of this vaccine of a condition that involved blood clotting, but something a little extra, which Dr. Daria will talk to us about. So as the government is sorting through this, there's a pause of a distribution of this vaccine. That's number 1. I know there's a lot of conflicting feelings about vaccines in general. And even if you do tend to vaccinate yourself or your kids, you might have questions about the COVID-19 vaccine. I just want to let you know I recognize that. It may not be the topic that we tackle today, but I hear you, I understand. And that's the job of journalism, is to shine a light, to give you more information so that you can make your own decisions. Smarter News, and the way that I hope to continue to build this, is that the news really works for you. You don't have to work to get your news. And so if this is a helpful conversation, I hope we can continue to do it. So kind of mix those 2 things together. Last thing I want to focus on is that although the context of this discussion is going to focus on women, because this condition has been found in women under the age of 50, and we're going to stay there. What's really important to know about this Johnson & Johnson vaccine is for those in the government who do want to vaccinate the population. The Johnson & Johnson vaccine was an important tool for them. It doesn't take a lot of extra refrigeration. It's easily transported, and it's also 1 dose. Sorry, that's a spam call. Is that the government calling me right now? What's happening? Instagram? Okay. So let me just rephrase that. So again, Johnson & Johnson is very powerful because it's a single dose. It doesn't need a lot of extras, and you can get it into communities. You get one shot into one person, and they have some immunity based on the research and based on the way health officials are speaking about this. So to pull this tool from the toolbox is significant, not just because what it means for women, but what it means for this plan overall by the government. You know, thinking about driving mobile vans into communities that could be at higher risk for COVID and are able to get that vaccination directly to them. So not only for the United States, but also for the rest of the world. So I just wanted to understand, kind of talk about the stakes here. So let me go ahead and see if I can pull Dr. Daria into our conversation, because she is the medical expert and she's going to be taking. I have some really great ones, by the way. Just so you know, excellent questions, and we're going to cover a lot of them. Oh, there she is. Hi, Dr. Daria. How are you?
How are you? Hi, everyone.
Well, did you see that I had a spam call right in the middle of this?
You did.
They just know when to bother you. You know what I'm saying?
They do. Did they sell you anything interesting?
No, I haven't picked up for years now at this point. I'm just gonna, don't call me. If I don't have your number, I'm not picking up. Let me just start with this. What is the condition? We want it to be very clear that it's not just blood clotting. It's not just that, but you've seen this condition as an emergency room physician. What is it?
So yes, you're right. Cerebral venous sinus thrombosis. Let's just call it CVST for the rest of the time, because it's quite a mouthful. It's a diagnosis we make in the ER. It's actually kind of a hard diagnosis to make. It's one you have to remember to always be thinking about. And you're supposed to think about it when you have, especially a young female, 18 to 48, 49, who comes in with a very severe headache, maybe neurologic symptoms, and especially if they're on things that can increase your risk of blood clots, like oral contraceptives, pregnancy, postpartum, or other things that are not just confined to that age group, like cancer, recent surgery, or other blood clotting disorders. 90% of people who get CVST have some other kind of pro-clotting, pro-thrombotic risk factor. So it's really important to know. And then these patients were also seeing apparently CVST plus low platelets. Kind of
what is a platelet, by the way? Because even on the calls, the FDA, CDC, everyone's just throwing on platelets, like everybody knows it. But we don't talk about platelets a lot in my household. So
I know, right? Really good point. So platelets are a key part of why our blood clots. So, you cut your skin, and one of the reasons you don't hemorrhage out and die from just a small cut is because your body is able to clot. It's a pretty complexly fascinating system. The first phase, called primary hemostasis, for you who want a new cocktail term, involves platelets. And then secondarily, you have secondary hemostasis, and that gets into your clotting factors, your hemophilia, things like that people have probably heard about. Platelets are the very first part. So they're really important for blood clotting.
Okay, so the condition with platelets then is doing what?
So what it looks like is happening, so the condition CVST itself is just a blood clot in a portion of your brain. So sometimes you may think, well, blood clot in my brain, isn't that a stroke? So a blood clot, the most deadly bad kind of stroke, is because there's a blood clot of your artery. These are actually blood clots of your veins. So it's a slightly different presentation. So just as a metaphor, I live in Atlanta, and we have 285 as our big highway that goes around. 75, anybody on the East Coast knows 75. 75 coming into the town, it's morning rush hour. An arterial stroke is like I just put a tractor trailer perpendicular on 75 going into town at 8 a.m. It's suddenly everything backs up. Slightly different is a venous stroke is if I put a tractor trailer on the other side of town, it's not going to immediately cause such a problem because not everybody's going to the other side of town, and it's going to take longer. So that's a venous stroke. It means that it's not, that's why 80% of people with CVST actually get better and don't have any permanent consequences.
Do they know
if
they
you
have
get
it?
treated? Well, yes, because you have to get treated. Yeah, because
Okay.
so that's what we saw for one of these cases, that they had delayed treatment. So if you don't treat it, then it can be very dangerous.
I want to get quickly to the questions, but one of the big ones is how do you present? And if you go into the emergency room, what are the telltale signs that this is something different than just like a really bad headache that any of us could experience anytime over the last year?
Right. Well, that's what makes it hard. And that's why CVST is one of those that we as an ER doctor, we're always trained, like no matter what, try to remember this. So signs and symptoms, really bad headache. They may have vision changes, double vision. They may have signs and symptoms of a stroke because that blood can get backed up eventually. So that could be weakness on any part of your face, any weakness in your arms or legs, or word finding difficulties. And then at the very severe end can present with even like seizures and a coma. So that's kind of, it runs the gamut. And I don't tell everybody I don't tell them that to panic. I tell people that so they can feel empowered to know what to look for.
Okay. Well, Amy had a great question, and she said, she just really got to the heart of it. Why is 6 people so significant when hundreds have had anaphylactic reactions to the other vaccines? It just doesn't make any sense for her. Why would 6 people lead to this domino effect?
That's a really good question. I tried to look up the exact number of people who had anaphylaxis. Looks like it's about 11 million for Pfizer, especially in the younger population. It's about 11 cases per million who've gotten anaphylaxis. And Moderna, it's 2 per million. I think one is anaphylaxis. There's something we can do. You're sitting there, you get your vaccine. That's why we monitor people for 15, 20 minutes or so. So if somebody does develop anaphylaxis, they're there and we can treat them. So I think that's one thing. I think CVST, it's a very serious condition. And I've asked that too, because I've worried that by them talking about this, we're going to take people who may have been concerned or people who weren't concerned about the vaccine, and now they suddenly are concerned.
Yes.
But the flip side, Jenna, is say they hadn't. Say they had said, you know what, this might be something, but let's keep issuing the vaccine. And then a week from now, we found out that this really was a thing. Like, then how would any of us ever be able to trust the FDA or CDC even more? So I think it was a rock and a hard place. And I think they decided to err on the side of saying, this is transparent. We don't know if there is something there. We need to pause and be safe.
That gets to a question from Lily, which kind of draws us into a broader conversation about this particular type of vaccine, which uses an adenovirus vector. By the way, we're all talking about this, like this stuff that we normally know. I know in medical school, you do, like, I've never ever heard this term before since the pandemic, but Lily is a great question. Isn't an adenovirus vector vaccine used in a lot of other vaccines? And talk to us through AstraZeneca as well, because AstraZeneca is not approved here in the United States for emergency use authorization. It is approved in Europe. And that was mentioned in this conversation yesterday about the similarities of conditions that are emerging.
Yeah, so it's I pronounce it adeno. British people often pronounce it adeno. You know, they every dialect. I remember I had my anatomy professor in medical school had a very strong Boston accent. So I remember she talked about the flexicapionaris. So I always remember like the way we all pronounce these things. So actually, there aren't a lot of vaccines that have an adenovirus vector. And I meant to actually look up because not the common ones that we use don't. There was even an Ebola one that had an adenovirus vector, but you're
Which
talking
is by
about
the Johnson and
Ebola.
Johnson, right? Johnson and Johnson
Yeah.
has that, and that's why
So,
it's a technology that people have been excited about looking at the
mhm.
research on.
Yeah, and I believe you're right. It's Johnson Johnson. Don't quote me on that, because that's just not something that we fortunately have been having to use a lot of lately. Is the Ebola vaccine? Knock on 30 things of wood.
Please,
But
right
no,
now.
it's not common. AstraZeneca and J&J both use an adenovirus, but otherwise it was used in some gene therapy in the 1990s in a case that it resulted in the death of a young boy. So it's not very commonly used. They both do that. One of AstraZeneca. One uses a chimpanzee adenovirus, one uses a human adenovirus, and they both deliver double-stranded DNA. Contrast that to Pfizer and Moderna, which uses the lipid bilayer to deliver mRNA. So there is that difference. So that is one of the questions. Is this signal that we're seeing, is it real? Because Jenna, we do have to look at the numbers, and we can get back to that in a second. But then the second question is, if it is real, is it related to the adenovirus?
Mm-hmm. And that would be, how do you even find that out? How did they even figure that out now?
So first, is it real? You have to look at the numbers that we expect for CVST. So CVST, you have about 5 to 10 per million per year. Right now, we're seeing in the J&J 1 per million in about 3 months of it being given, 2 months of it being given. So they're going to have to look and see if there are more, because then you could argue that this is just the expected prevalence that we would expect to see for CVST in this population. In which case the question, is it related to the vaccine at all? Or is this just what you would see? Of the 7 million people who got the vaccine, some portion of them were going to be in a car accident the next day. Was it the vaccine or not? Whether they've gotten the vaccine or not. So you have to look and say, was this just due to chance expected, or was this related to the vaccine? We do know also CVST is more common in younger women. And we talked about the risk factors of OCPs and those things, but they're going to just have to look. And they'll also, I really want to know, were these patients on blood thinner, not blood thinners, were they on prothrombotic medications? Did they have other risk factors, or were these very spontaneous? So they're going to have to go through entirely and just go through with a fine-tooth comb for all their cases.
Lois had a great question. Do other existing vaccines like flu and measles have a similar risk to blood clot? Is blood clotting something that is a risk? No, so not for typical vaccination.
It's not something that we've seen. No.
Okay. Melissa had a great question. She's a 39-year-old woman who received the Johnson & Johnson vaccine. She said, is there anything I can do to prevent having a blood clot?
Unfortunately, well, yes, you can avoid any of those prothrombotic things. So if you are on oral contraceptives, if you are a smoker, anything like that we know, yes, those are ways that you can do that. Otherwise, say you're not doing anything that's prothrombotic, then you just watch, I would say watch for the symptoms. And remember, these cases all happen within 6 to 13 days. So I'm telling people, watch for 2 to 3 weeks. If you have any high risk of clotting, then I would, and if you have a hematologist or a PCP, follow up with them as well to see if you need to have labs checked or something.
Just following up with that, E. Keys had this question. She said she also got the J&J vaccine, and now she feels really scared, and she feels like maybe she got an inferior vaccine or that she hurt her body. How would you, if this was your patient coming to you with these concerns, because a lot of doctors are getting that call, how would you speak to her about that?
So just like as a human, I feel that. I feel you. Like when you said that she said she was scared and that she hurt her body, none of us want to do that. We all are taking this vaccine because we're trying to get better. And so then to get the news that what you were trying to do to get better could have harmed you is terrifying and frustrating and all of those things. I would say, I don't want people, when I'm telling my patients, is please don't panic. Remember, these numbers are still 1 in a million. And to that one person, that matters a lot.
Of course.
But it is still 1 in a million. So remember that. And otherwise, it's just really a watching and waiting game. Know that your chances are very small.
Okay. Great question from Adries, if I'm saying that correctly, about the VAERS data. Before we get to that, VAERS data is what? What is VAERS data?
Yeah, so that's a vaccine adverse events reporting system. And sometimes it seems like VAERS is held up as this like Bible of source of all truth. And so we have to put it in context. VAERS is great, but it's a way that anybody can report anything at all. I think there's always that famous case where somebody said that the vaccine made them turn into the Incredible Hulk. So people can go on there and report things, and I go on there because I want to see.
Wait, someone can report that it turned, and it's not. It's just
Yes, you can go ahead and report anything, and you.
Well, is that real? Because if there is the Incredible
Hulk, they did not.
I want an interview.
And I'd like to become that Incredible Hulk with some anger management therapy, perhaps. But so VAERS is really good for just saying, throw all your information in here, and then we're going to sift through. But so as a result, you cannot look at VAERS. Somebody said, there's several hundred of thrombosis and different things. You cannot look at it as just as fact. So I went to see how many cases there are of thrombosis, and I started looking through all of the different ones. And it's interesting. One of the cases of thrombosis, you read it and you realize that they said I had a blood clot. And then I read it and it turns out that they had a bloody nose and there was a clot in the blood. Or another person had said I had a blood clot in my period blood. So, but they had labeled that as a thrombosis. So that's okay. A layperson doesn't have to know exactly what we as scientists expect a thrombosis to mean. But it just means that we cannot go and look up everything in VAERS for thrombosis and say every single one of these people had a blood clot.
Got it.
So we got to take VAERS with a grain of salt. Somebody says, does that make VAERS worthless? No. VAERS is very useful, again, for finding signals, for saying anybody who has a problem, this is just level playing field, go put it in there. But then we and researchers have to then look at that data to figure out what is real, what actually has a connection, and what maybe mislabeling or maybe just not really associated with an outcome. And that's okay. We don't expect patients to have to figure that out. We just want them to give the data.
Interesting. Tiffany's saying on our live that reporting is actually hard to do, that you have to know quite a bit of information to get up there and to submit to VAERS. So, but what you're also saying is we have to weigh that, just like a headline, we have to go a little bit deeper and find out, well, if there was blood clotting, what exactly is that?
Right.
What was that condition? Who is that person? What sort of pre-existing conditions? What sort of medications are they on, to really understand how to group it? Okay, so it's a little bit of everything. But we're also not talking just about thrombosis with Johnson & Johnson, correct? Like that, I know it's easier to talk about blood clotting because it's something that I think we kind of feel like we understand versus what this very specific condition is, which involves blood clotting, but isn't just that.
Yes, so we're seeing this blood clot CVST plus thrombocytopenia, which means low number of platelets. And why is that happening? We can see right now we're hypothesizing entirely, but what it seems like, and why this is happening more in women. Women in general, we are more likely to have those kind of high increased risk of blood clots for all those reasons I gave earlier. And women have somewhat of a more active immune system than men. So that could be why we're seeing men having worse outcomes from COVID. It's why we see more women with autoimmune disorders than men. It could be hormone related, it could be a variety of different things. So our immune system potentially is more likely to have that autoimmune reaction. So what we see, there's another condition called heparin-induced thrombocytopenia, which people I just mentioned, HIT, people may have seen it. And the one hypothesis is this could be a similar mechanism in which the vaccine, whatever part of the vaccine, is leading the body to develop antibodies against the platelets. So it becomes this state where you're both consuming your platelets and clots, at the same time your body is identifying them and kind of saying, these are foreign, I'm going to pull them out, put them into the spleen and pull them out of circulation so that their platelet numbers drop. So you're getting blood clots and your platelet numbers are dropping.
And that's a dangerous situation.
Yeah, it can be a dangerous situation depending on how low your platelets get.
I know you have to run. I am going to tell my husband tonight that I do have a more active immune system than him, which I think if there's other women watching it's just that we're about making people smarter. So that's like something we could just kind of throw in there.
Did we just find out why man flu is such a thing? Like
man flu is the real thing.
Maybe that's why we don't get
something on it. Yes, we don't get man flu. That's for sure.
So, and somebody here is asking about DIC. So
what is
Megan is
DIC?
asking that. So DIC is another situation of errant blood clotting and platelets. So what happens in DIC is it's often kind of the end stage of many different diseases. You can see it. We can see it actually. The fetal tissue can happen in pregnancy. Sometimes you see women after delivery if they have a very a high hemorrhage delivery, meningococcus, a bunch of different things can trigger it where an infection or some other tissue causes your body's blood clotting system to go awry. And it starts to consume and create lots of clots. So you start to clot all over your body, but at the same time, it's rapidly degrading those clots. So you also are using up all your clotting system. So you're simultaneously bleeding. It's a very dangerous, very awful situation.
Well, wait a minute. What isn't one of the side effects? And I know you've encountered COVID patients in the ER. Isn't one of the side effects of COVID blood clotting?
Yes.
So, but different kinds. We're talking about different.
Well, not necessarily. Yeah, we haven't seen low platelets with COVID. So that part is strange, and it could be, again, an autoimmune sort of thing. The blood clots we are seeing with COVID, and when I had done a little bit of research on this, and it looks like around 50, different papers look like about 15% of people with COVID end up with some sort of blood clot. I don't know what that is in the younger population. I couldn't find that data. But yes, absolutely, we see blood clots with COVID. And a lot of people who end up having heart problems from COVID are because they had blood clots in their lungs. And that's especially disastrous. So that's why it's always a calculus of risk versus benefit, because we know you have a risk of blood clots with COVID as well.
And I want to get to your research, but final question for you here about the focus on women. Going just back to it, I know we have to look at medication, birth control. We have an active immune system, but why would women, are there any other reasons hormonally that women would be more susceptible to this, even if they're not on birth control and they don't have any other pre-existing conditions?
Not necessarily just that the estrogen in itself. Actually, men are more likely to have thrombus, blood clots, like in their heart and things, sometimes than women. That estrogen is actually protective against that, but it's often the combination that we get through oral contraceptives or peripartum and those different stages that increase our risk. So I think it's the increased coagulability, and I also think it's a combination of that plus our increased risk of autoimmune that could be leading us to see these things.
What's the next thing you're going to be watching for from health officials? What's the next thing that you want to know?
So what we want to see was were there 6? Are there more? I think there are a couple reasons that they paused it, and let's be clear, they paused it for one, to figure out if there is any real data behind this signal. Number 2, to see if you have more people who've had this condition, please report them. And number 3, because they want us as physicians to be treating this differently. So they're saying CVST, they don't want us to give heparin, actually, which is therapy that many doctors may otherwise reach for. They wanted to make it very clear that you need to be reaching for different medications because there is this complex of CVST plus thrombocytopenia. So there were multiple reasons. They really wanted to make sure that physicians, if we start seeing this, are treating it the correct way, which is different from how we'd classically treat it. So we need to figure out if this is real, how many numbers there are. And I think it is right to pause it until we know if there's a real signal here.
A lot of comments about feeling like we're part of an experiment, like an ongoing experiment, maybe no one really in the driver's seat, feeling that little out of control after a year of all of this and back and forth information. It's a natural way to feel. Can't help it.
I mean, I think we are part of a natural experiment, Jenna, but we're part of an experiment because COVID came up. It's not because of the vaccine. It's because COVID became a thing. The vaccine is our attempt to react to it. And I think I'm trying to see some of these comments. I've not been doing a good job of
there's only so much multitasking.
Right. My brain is short circuiting. So if I didn't answer comments, Jenna, just send it to me. But I think we're doing the best with the information we have, and with the data that we have. And that's why I think the general public is seeing us kind of think out loud too, because the information that we have changes one day to the next. I think we have to really be transparent about that. And I think that's part of the problem, is that there wasn't as much transparency in the first 6 months about everything from masks to PP'd, anything else. And I think that's been frustrating. And I think this does highlight in all forms of medicine, we're always learning, Jenna. I mean, the stuff I learned in residency, and I'm not, things I learned in residency 10 years ago, some of them we now know that we've learned a lot better. I mean, we learn in medicine. That's the point. You want us to be learning. I did an ER shift last night, and then I came home and I was pulling out my literature here because I've been reviewing stuff today, because it's a constant, that is medicine. We are constantly learning. If you're not constantly learning, then that's a bad thing for your patients. So I think that's part of it, is we're learning. We have to learn how to learn and also convey that to the general public in a way that helps them understand that what we're doing is benefiting medicine and benefiting our patients.
Speaking of learning, you did some really interesting research looking at VAERS, because, and in part because we've had these conversations where people have been concerned about the side effects of these vaccines. And so can you just give me the 30 seconds, because once we say goodbye to you, I'm going to pull up the document so people can see what we're talking about. This unique research that you did specifically for people under the age of 50 for the risk of COVID versus the risk of the vaccine.
Yes. So I did this for myself. And I wanted to share with people, because again, when we're talking about the risk of the vaccine, yes, there are risks. I won't pretend that there aren't. I'm not going to Pollyanna and say that just get this vaccine and then there will not be risks. There are risks to anything. Any treatment I give you, whether it's a vaccine or an antibiotic, there are risks. But what is important is the calculus is the risk of this less than the benefit of this. So, and I wanted to look at 1840 to 49, because I think in the older population, we know there's a lot of risk of death in the older population from COVID. And so it seems like an easier decision to get the vaccine. And the younger population, people are saying, well, should my chances of death are lower. Granted, with the variants, we're seeing even more cases in the younger population. But so we looked exactly at that. And so what are the risks of death and from the vaccine and from the COVID, from catching COVID? So in the 18 to 49-year-old range, and I'm looking over here because I have the table over here, the risk of death of COVID is about 0.08%. The risk of death from the vaccines are 0.0001%. So, significantly different. We just looked at all of that. What are the risk of blood clots? The risk, because we're seeing blood clots, but the risk of blood clots with COVID, 15%. The risk of blood clots with Pfizer, for instance, was 0.00002%. So that's why we wanted to look at that. And, because I think I know some of your viewers may not want to get, will choose not to get the vaccine. And that's their own risk benefit calculus to make. I can't decide that for anybody. But I wanted just to give people the data so you have the numbers, trying to pull from VAERS and from other data so that you can make your own more informed decisions.
Okay, I want to show everybody what it looks like. I'll direct them to your site and to your Instagram. I know you got to go get your daughter. I'm looking at the clock. So thank you, Dr. Daria. And we'll continue the comment section underneath this video, and maybe we can kind of jump in and out. I know people are going to want to hear more from you. So thank you. This is like the very first chapter, the very first information we have on Johnson & Johnson. So I appreciate you being willing to talk about it when we don't have a lot of information and work through it.
And can I answer one question? Somebody just said, who ever heard of dying of a blood clot from COVID? Like many of my patients. We can't minimize this. And I don't want to, I'm not trying to scare people. There's, lots of people are healthy, but when we can't make glib comments of whoever heard of dying from a blood clot from COVID, the patients that go into cardiac arrest that I take care of. And, Jenna, that's why we're here. Like I take this stuff seriously. I don't want anybody to have a risk from a vaccine. I don't want anybody to feel like they are forced to get a vaccine. I just want them to have the data, and I want them to stay as safe as possible.
I think we feel that. Thank you, Daria. I appreciate it. All right. Bye. We'll talk to you later. I'm sure we have a lot of questions. Thank you for that. All right. Let me see. I'm going to pull up your research by Daria.
Okay. Okay. I should go, right?
You got to go because I can't pull it up unless you go.
Okay.
I want to show everybody.
Bye.
I know there's a way for me to say bye, Daria, but we'll let her go. So I hope that's helpful to you. I do want to show you what her research looks like because it's right on her feed. It's also on her website, and it's cool. She took some time, worked with a researcher, pulled the information and put it in a chart. And so I saved a screen grab of the chart and I just want to show it to you. And again, this is not Bible. This isn't like, this is the only thing out there. This is just another tool for you to look at if you like, and if you don't, like, totally cool. I'm all about just showing you more rather than less. So this is the chart that she developed. I wonder if I can move myself off of it. It doesn't look like I can. So you can see what she did on the left-hand side. She looked at hospitalization, cardiovascular inflammation, blood clots, Bell's palsy that came up in the Pfizer trials, and looked at what do you see with COVID-19 versus what do you see with the vaccines. And this is the chart that she put together. So you can kind of look and look at the actual percentages for yourself. So this might be an interesting tool for you to see. And, if it's not your deal, no big deal, right? So hopefully this has been helpful for you guys. I know there's a lot of information coming at you. It is, every moment that we feel like it's smarter news, oh, it's going to slow down, or we're going to get a chance to catch our breath, or we're going to have a second, we don't. And that incoming information is enough to cause a lot of confusion and concern for anybody. I know I feel it. So our hope is that we lighten the load, that in this cluttered news space, we provide a little bit of respite so that you have a corner of the internet or social media that you can go to and hopefully access small bites of high quality information. So continue your comments if you like. I know Daria reads them and often answers, and I'll be looking forward to your questions and comments as well. You're an inspiration to me. You're a driver of the editorial process, and I'm really honored to be able to work for you during such a significant time in all of our lives. I think about it regularly. All right, guys, have a great day. I'll be back with more on smarternews.com. Bye.